This is a tutorial that will give you some methods you can use to teach residents how to choose an imaging protocol. So a prerequisite for this is to ensure that the residents realize that the quality of our interpretations is totally dependent on the quality of the imaging examinations, and it's up to us to ensure that all of our scans are performed optimally. Residents won't inherently be able to start protocoling unless they have some background knowledge. So they'll have to have some kind of pre-work. I'm a body imager, and so in our section we created an online tutorial for how to protocol body imaging examinations. And this gives them the background they need in order to protocol studies correctly. There's information about different timing of contrast enhancement and what the organs look like after IV contrast is given. It defines the various phases of enhancement that will be the terms that will be used in our protocols. And it gives information about target and peak organ enhancement, and as well as the enhancement pattern of certain types of tumors. So we give them that background information before they arrive on our rotation the first day. I've divided the methods by levels, and the levels correspond to the degree of sophistication of the resident. So level 1 is a pretty basic or new resident. And what we typically do is just simply ask them to take a stack or a list of imaging exams and go ahead and choose a protocol and make that a prelim. They then bring those to us and we will go through them and we'll critique their choices, and it's an opportunity to teach and to reinforce some of the concepts that were on the pre-work. So this really focuses on defining the level, the phases of imaging, and some of the information that was in their tutorial. And you may want to keep this pretty basic. For instance, if you're a body imager, just say to the resident, okay, pick out the cases of just CT abdomen and protocol those. Or if you're a neuroimager, you may ask the resident, just protocol any of the requests for spine imaging. So you can keep it really narrow if you'd like, or you can make it as broad as you want. Level 2 is an opportunity to teach not while you're actually protocoling studies, but during a readout. So look at the case in front of you and ask the resident, did we perform the scan correctly? Why do we do it this way? Why do we have sagittal images as part of our spine protocol? And also an opportunity to think about, were there other tests that would have been more sensitive or specific for the diagnosis in question? Should we have recommended an MRI instead? To remind the residents that protocoling isn't just about performing the scan correctly, but looking at the clinical indication and making sure that we're imaging it correctly as a whole. Outside hospital reinterpretations, to me, I think are the jackpot, because most outside institutions will do things a little bit differently than your own institution. So it's a great opportunity to analyze how they perform the scan and to critique their methods. Have the resident assess whether or not that scan is technically adequate for the particular indication, and is it sensitive enough for that indication? Also ask them, if we were to perform that scan at our institution, would we have done it differently and why? So I think these are really good learning opportunities. Level 3 gets into the weeds a bit. It's a little bit more detail-oriented or granular, and level 3 is more appropriate for more advanced residents. And it's great for things like MRI, where you have so many different series and sequences that are performed. So ask the resident what a particular series or sequence is used for. Why do we include the T2 axial images as part of this protocol? What do we look for on those? What kind of information might you get from the T1 out of phase that you don't get from the in phase? Or if we eliminated this particular sequence, how would that limit the diagnostic utility of the scan? So that really gets at a more granular component of the different protocols that we have. I also like an opportunity to teach protocoling in a cross-modality way. So in other words, if you're on ultrasound and you find a liver lesion and you ask the resident what they'd like to do with it and they recommend a follow-up, instead of just having them say, follow it up with MRI, push them a little bit and prompt them to ask, okay, we can follow it with MRI, but how would you perform the MRI? Does it need contrast? What protocol would you use? What type of contrast would you use? To help them remember that the information they're learning on each rotation isn't just siloed for that rotation. So I like cross-modality protocoling concepts as well. And level 4 is more sophisticated, more appropriate for a senior resident or a fellow. And this is a method I use where I will have somebody protocol a bunch of liver MRIs, for instance, and then go through it with them and ask them to compare and contrast the subtle nuances in different histories that led to them choosing different techniques. or point out something they did, like, I see here you chose an extracellular agent, whereas in this case an intracellular agent. Can you explain why? Just to reinforce and ensure that their thinking is correct. You can also offer different scenarios. For instance, if someone chose a two-phase liver protocol and that is the correct protocol, say, okay, this is the correct protocol for this indication, but had this patient had an ablation previously, what series or sequence or additional phase might you need for this examination? So level 4 is really more advanced and more sophisticated. And lastly, try and make connections whenever you can. Try to connect to a prior case that you may have read with a resident or to a prior clinical experience they had. Anytime you can make a connection, that emotional reinforcement helps them retain that information. It's really valuable to teach from scans that were performed incorrectly or suboptimally, and it's really valuable to teach off misses, particularly misses that were made because an initial imaging study wasn't performed with optimized technique. So good luck. I hope this tutorial was valuable.